Okay, so once again, welcome. Thank you for joining us, taking time out of your busy afternoon to learn a little bit more about some of the SOPs that we're running. And today we're going to be talking about obviously contact tracing. This is basically an introductory training. So just at this point, I'd like to point out that this is training specifically for people who are going to be involved in contact tracing. Like, for example, here in Suva at the moment, we've hit mitigation phase. We're not doing as much contact tracing as we used to do when we were still in containment, but this is definitely applicable to the west and definitely to the north when finally, touch wood, unfortunately, you likely will get cases. So this will give you some knowledge on how to run the contact tracing. Thank you. We'll move to the next slide. Okay, so once again, I'm Dr. Alipate, and we're going to have some very interesting presenters today. We have Dr. Elias Forbin, who is a medical doctor from Cameroon, where he's originally from. He's obtained a MPH degree with a focus on epidemiology and biostatistics from the University of Melbourne. Dr. Elias is a Master of Science degree in Health Informatics from City University in London, and he's been working with WHO since 2015 on a number of outbreaks in Africa, including the Ebola outbreak in Guinea and in the Democratic Republic of Congo, the pneumonic plague outbreak in Madagascar, wow, and the COVID-19 response, obviously. In addition, Dr. Elias is supporting Pacific Island countries to strengthen surveillance and contact tracing. So big bula vinaka, and welcome to this webinar today to Dr. Elias Forbin. We have Julia Maguire, who's an infectious disease epidemiologist also with the World Health Organization. And Dr. Julia completed her field in epidemiology training in Australia and has since worked in Australia, Bangladesh, Samoa, and the beautiful islands of Fiji. Julia has been supporting the Pacific Island countries and areas with COVID-19 surveillance, preparedness, and response since the beginning of the COVID-19 pandemic, and with the vaccination rollout in more recent months. Dr. Julia has been embedded within the Fiji Ministry of Health and Medical Services since April 2021, particularly in IMT, the planning and surveillance team, and has been supporting data collection, management, and the analysis of key data to assist with the response. So welcome, Dr. Julia as well. And last but not least, we have Dr. Philomena Renandi. Everybody would know her as one of the vibrant pathologists at the Colonial War Memorial Hospital. Philo has completed her master's, and she's been gained quite a bit of experience in the war against COVID. She's moved around quite a bit, and she's now heading the CWM SORTS team. So as you can see, we have a very interesting lineup with a lot of experience in contact tracing. Yeah? So just very quickly over the agendas, we're done with the introductions. So housekeepings, please again, keep your mics on mute. We would encourage you to ask as many questions as you want to clear up any doubt about contact tracing. You can do this by writing your questions into the chat forum or waiting till the end, where we'll open up the floor for people to ask or make some comments. And that'll be right at the end of the discussion, and then where we have questions and discussion, and then we'll have the closing comments. And so, Kerkere, everyone, if you could just put in your name, your role, the division that you, or subdivision that you work in, and also your email address, and we'll be very, very happy to contact you via email. Once again, everything I've just mentioned is there, and this is going to be a recorded session. We'll upload it, and we'll definitely share the links later on. I think that's the end of me. So once again, we're running these programs, we're running these webinars Wednesday, Thursday, Friday this week. So tomorrow is going to be another interesting one on the rapid diagnostic testing, and that's going to be hosted by Dr. Alicia. I know a lot of you will be interested in this RDT and how it differs from the PCR testing. So that's tomorrow, 6 to 7. And then on Friday, 6 to 7, we've got IPC again, this time on the management, safe management of a COVID deceased person. So pretty interesting next couple of days in terms of the webinars that we've got here. Those are just some of the SOPs that we've discussed in the past. And again, if you put in your email addresses along with your names and where you are, we'll definitely get back in contact with you and send you the latest SOPs that we have. But for now, we will hand over the mic to our speakers and they will jump straight into it. Naka?
Hi, thank you very much for the introduction, Dr. Alapati. I'm not quite sure what those blue lines on the screen, if anyone else can see those, sorry about that. But I just wanted to start today by saying thank you to everyone for joining the call. I know that we're all really busy and exhausted after many months of battling this current outbreak. So we really appreciate you taking the time to increase your knowledge of contact tracing so that you are hopefully better equipped to assist in the response. On the screen, we have an outline for the areas that we will cover today, including a quick revision of COVID-19, contact tracing definitions and recommendations, and roles and responsibilities within the contact tracing team. The content today is based upon the contact tracing SOP being used in Fiji that has been or will be shared with you very shortly. So before we get started, I'd wanted to provide some context to this training. So we developed this training to be an introductory or refresher session on the basics of contact tracing for people that are actually going to be conducting the contact tracing themselves, as Dr. Alapati mentioned. So the training will focus on key principles in the containment phase or low transmission scenarios, as we currently have in the Northern and Eastern Visions here, as you can see in this table, where the response aims to prevent and rapidly control new outbreaks. And the target is all contacts that we want to follow up with. As we know, Central and Western divisions are currently in the mitigation phase as they're experiencing higher transmission of COVID-19. This contact tracing priorities differ in this scenario and aims for early identification of severe disease, reducing transmission, and identifying and intervening in priority settings, in which we target contact tracing to people at high risk of severe disease, so they can be identified and provided appropriate care. So this training is not targeted at the mitigation phase strategies, but Central and Western divisions may return to the containment phase, at which point this training content would be relevant again. And we also in the future might be able to provide more trainings targeted at the mitigation phase strategies. So at the end of this session, we hope that you have more understanding of what is contact tracing, who is a contact and what are the different types of contacts, the contact tracing process, the tools used in contact tracing, and your roles and responsibilities within the contact tracing team. So we are starting with a quick overview of disease transmission, but I acknowledge that a few people on the line will probably be very aware of this, if not everyone on the line. So COVID-19 is caused by the SARS-CoV-2 virus, which spreads when droplets containing the virus are released from an infected person when they sneeze, cough, sing, or really any action that allows little droplets to come out of the nose or mouth. As such, the virus is mainly transmitted from person to person, via direct contact or being nearby, but can also spread when the virus lands on objects or surfaces that someone else goes on to touch. Commonly, these can be doorknobs, shared electronics like laptops, or public surfaces like lift buttons or handrails. Now we're looking at the transmission timeline for COVID-19 from person to person and where contact tracing fits in. So you will see that we are starting with person 1. This person comes into contact with a case, and that is at day 0, we're calling it, and then they become infected themselves. So this person may not show symptoms of infection until day 14. This is known as the incubation period for disease, which has been shown to vary by the different virus variants, but the average is around 5 days. In reality, this person may start showing signs of disease from anywhere between 1 to 14 days, or not at all if they're an asymptomatic case. In this example, person number 1 has symptoms on day 14 and is identified as a case. When person number 1 was symptomatic, they had a contact with person number 2, so it's down here. Person number 2 is likely to have a 5-day incubation period just based upon the average before they show symptoms on day 19. This is the time when the contact tracing can identify this contact and place them into quarantine so they don't continue the spread of disease and before they become symptomatic and have a higher chance of infecting others. So rapid detection and investigation of cases enables identification and management of contacts. It is recommended that contact tracing be initiated at this earliest point before an illness becomes infectious, thus taking advantage of this window of opportunity to prevent more cases from occurring. So I'll quickly touch on the COVID-19 case definitions that are currently being used in Fiji, and you will also find these in the contact tracing SOP. The definitions include suspected, probable, and confirmed cases. So confirmed cases are those that test positive via the gold standard PCR testing, and in some situations also via rapid diagnostic tests, which I won't really go into anymore. So sometimes testing isn't available, or it may take a while to get the results. So we initiate contact tracing for people who have not necessarily had a positive test result. And so these are the probable or suspected cases. Suspected cases are those with symptoms and recent travel history where there's transmissions, that's this one here. Or they can be with symptoms and have contact with a known case, or they may be hospitalized with severe respiratory illness. So the detection of any types of these cases should trigger contact tracing. So what is contact tracing? Contact tracing is a public health response strategy for managing infectious diseases and is also used for other infectious diseases such as measles. It is the process of identifying, assessing, and managing people who have been exposed to COVID-19, so have been near a case, in order to prevent onward transmission, which is done by keeping the contacts in quarantine for the incubation period of the infection. Effective contact tracing requires rapid identification and investigation of the cases, thorough identification of the contacts, and appropriate and effective quarantine. And high intensity contact tracing should be maintained for as long as possible, but the resources may be overwhelmed, and when the cases get too high, we can change the strategy, as I've mentioned before, with the mitigation priorities. So how does contact tracing work? So it all starts with an infected person showing signs and symptoms consistent with COVID-19, or someone with COVID-19 positive test result. This is the red person here. After identifying the infected person, they are asked about their contacts. You then alert the contacts of their exposure and potential risk for infection. So now you have identified the infected person's contacts and you have done your assessment about exposure and risk. So after that, you manage the contacts by putting them into quarantine and monitoring their symptoms. Contact tracing has both benefits and limitations. The obvious benefits are minimizing potential spread of disease as early as possible. But one of the other benefits is that during contact tracing, you can take advantage of the situation by educating the infected people about the steps they should take in order to avoid spreading the virus, such as isolation of the case. You'll also be able to help people who are exposed to the virus by separating them from others in order to stop the spread of the virus, so quarantining of contacts. Another benefit is taking the opportunity to link infected and exposed people with the existing community resources while in quarantine and isolation. There are limitations, however. First, it's almost impossible to stop asymptomatic spread, since interviews usually happen after symptoms appear, during which time the infectious period has gone past. But this does not happen with asymptomatic people unless they happen to have been tested and received a positive test result, thus starting the contact tracing process from there. The second limitation is that for contact tracing to be effective, you need to do it quickly, and we have that short window of opportunity. Contact tracing has potential for also transgressing personal privacy and confidentiality if not done correctly, which is why training is important. So first here, I'm showing the WHO definition of a contact on the slide. So a contact is a person who experienced any of the following exposures during the period 2 days before and up to 14 days after the onset of symptoms to a case. So this is a little bit different for asymptomatic cases as well on there. So those exposures are face-to-face contact with a case, direct physical contact, direct care for a patient with probable or confirmed COVID-19 disease without the proper use of PPE, and other situations as deemed appropriate by the local risk assessment. But next I will show the definition that is being used by Fiji, so in the SOP as well. So we have a primary close contact. So this person is defined as having had face-to-face contact of any duration or shared a close space for at least 1 hour with a confirmed case during their infectious period. The exposure may be any duration depending on risk setting, such as transmission has already been proven to have readily occurred. There are concerns about adequate air exchange in an indoor environment, or concerns about the nature of contact in the place of exposure, such as if someone is shouting or singing, it's increasing the risk of exposure there. So being exposed to a setting or exposure site where there is high prevalence of infection, so this could be a community where there is community transmission, or unprotected exposure in a quarantine hotel for return travellers, for example. Or someone who has been in a venue where transmission has been demonstrated to have occurred during the time frame in which transmission would be expected to have occurred. Next, we have a casual contact. So this is someone who has been in the same setting with a confirmed case in their infectious period, but does not explicitly meet the definitions of a primary close contact. So it's really at the discretion of the public health team to either classify someone as a casual contact or as a primary close contact. This may be relevant in super spreading events where there is evidence of transmission occurring to people who do not meet those primary close contact definitions. Then finally, we have secondary close contact, which is also known as a close contact of a close contact. So this person is defined to have had face-to-face contact with in any setting with a primary close contact from 24 hours after the primary contact's exposure to the case. So we investigate these types of contacts when resources allow. Identifying secondary close contacts can really help to stem the spread of disease transmission before transmission has had a chance to occur. So I'll pass over to Dr. Elias now, who will go through the various stages of contact tracing process. So these include contact identification and listing, informing contacts, contact management and follow-up, and finally, discharging contacts. Thanks, Dr. Elias.
Thank you, Julia. We will proceed with the first stage or the first step of contact tracing, which is identifying these contacts, as we have seen, and listing them. So to identify, it involves interview with a confirmed case to identify all persons who were exposed during the infectious or the contagious period of the confirmed case. If you don't have an interview with this confirmed case, you are not doing contact identification. You must discuss with the case so that he tells you which people were exposed to his situation. So contacts are identified by asking about the case's activities and the activities and roles of the people around them from 2 days before onset of symptoms or 14 days after onset of symptoms for a symptomatic case, or if it is an asymptomatic confirmed case, 2 days prior and 10 days after sample collection was performed. So, next slide. Now, how do we do this identification? So the investigation team should have an interview with this case, and this interview could be virtual or it could be in person. If you're doing an in-person discussion with a case, of course, you have to take personal precautions like putting on a mask and observing at least 2 meters between yourself and the case. You should discuss with the case and let the case explain to you such that you can map out the activities of the case, including work, visits, recreation, use of public transport, gathering events, and entertainment. These activities as explained by the case are then listed by date for chronology, and precise key persons exposed to the case are identified. All contacts identified, therefore, are registered in a contact listing form. So we will see later what a contact listing form is. It is a tool for contact tracing. Again, the proximity support applications that we know, like the Care Fiji app, supports this identification process. So when you're doing your identification, after interviewing or discussing with the case, you can also use the Care Fiji app to supplement the identification of people that have been exposed to this particular case. Next slide. After you have identified your case, you must inform them of their exposure. This is the second step of contact tracing. So all contacts identified should be contacted, either virtually again or in person. We should inform the contacts about their risk or their exposure. And we should tell them the process and rationale for contact tracing, as Julia just discussed. We should also inform them what are the symptoms and signs of COVID-19 they need to look for during the monitoring period for contact tracing. We should explain to them how quarantine, as we would see, is organized and supported. We should also share practical measures to reduce risk of contaminating others further. So without wearing a mask and without maintaining social distancing, your contact tracing process is not complete. We should also explain how testing will be organized and follow up if required. For example, we can have people who become symptomatic, and we should explain to them the person they should call if they are feeling unwell. It could be the contact tracing team, it could be the division's COVID-19 helpline, or it could be emergency services. We must share this information with the contacts so that they can reach out for information. Next slide. To talk about quarantine, which actually is a key notion in the contact tracing process. So quarantine is the separation of persons or the restriction of movement of persons who have been exposed to a case, a confirmed case, but who are well from others to actually prevent the spread of infection and contamination. As Julia explained, we must identify these contacts rapidly, making sure that we observe the window of opportunity where these contacts are not yet transmitting COVID-19. So quarantine can be done at home, or it can be done in designated quarantine facilities, as it's the case in Fiji. Quarantine must be supported with food, water, and personal protective equipment. So it's not enough to say we are going to keep these people in a designated health facility. We must ascertain or make sure that they have food and that they have water and that they can continue living on their lives. The point is just to restrict their movement and to take precautionary measures to prevent spread. So quarantine and isolation are different. So isolation is the separation of symptomatic persons so that they do not infect other people. So know the difference. Quarantine, we're talking about contacts, people who are well, who don't have the disease, while isolation is for people who are sick and unwell. Next slide. So just to explain to you how we would calculate your quarantine period. So we have 4 scenarios here. The first 2 scenarios, scenario 1 and scenario 2, are practically ideal situations. In the first scenario, you would have a contact who has had a last date of contact with the index case. For example, it's on the 1st, the last date of contact is the 1st, let's say the 1st of August. From there, you will count 14 days, and therefore the last day of follow-up or the last day of quarantine for this contact is the 15th of August. Same situation for scenario 2. Just the difference is that the case in scenario 2, the contact and the case are living in the same household, but they have maintained distancing and there has been no further contact apart from the last date of contact, which is the 1st of August. So quarantine would definitely end on the 15th. The third scenario could be, actually some scenarios that we could observe on the field, a situation where you have a contact who had a last date of contact with a confirmed case on the 1st, then later had another exposure with this case on the 5th of August. So you would have to move from 4 days from the 15th. So if the last date of contact was 1st, then the last day of quarantine is the 15th. If it changes now and the last date of contact is the 5th, then you add an additional number of days, which corresponds to the 19th, to be the new quarantine date. The essence is that we should use a last day of exposure to monitor if there will be signs for COVID-19. In the last scenario, scenario 4, we have a pretty complex situation where the contact and case cannot really manage to stop contacts between each other. It could be the case for a mother and a child. So in this situation, if the last date of contact is the 30th, for example, then we can see that we would have to take into account what the average infectious period for the mother is. Let's say it's 10 days. So we will count 10 days, and after 10 days, which is the 9th of August, it will correspond to the last day of contact for the baby. So eventually, this will be the point where the mother is no more infectious, and we can continue to monitor the baby if the baby will have signs and symptoms, which the quarantine period in this case will end on the 23rd, which is 14 days after the last date of infectiousness for the mother. So a negative test during quarantine does not reduce your quarantine time. So quarantine time is 14 days as from the last date of contact with a confirmed or probable case. Next slide. So monitoring of contacts is the third phase of contact tracing. And I should say this is the base of contact tracing. And monitoring of contacts is usually done by contact tracers, community volunteers. What do? So they have to get information about the health status of the contact. Monitoring just means we want to know what is the health status of that contact. Is he sick or is he well? So monitoring could be done by self-reporting, or it could be done through phone calls from the contact tracing team. It could also be in-person visits, and if it is in-person visits, it should be supported with measures to reduce contamination. Contacts must be given the telephone number of the contact tracing team. I should insist that the relationship between the contact tracer and the contact should be a good one, such that the contact can always confide to the contact tracer the health situation of the contact. All information is entered in a daily monitoring sheet for COVID-19 contact, as we would identify what a daily monitoring sheet is all about. It's one of those tools that we use to monitor contacts. Next slide. So the last stage, if you've monitored your contact for 14 days and you've had no problem, then you have to discharge. So the last stage for contact tracing is contact discharge. So the daily monitoring of the health status of a contact stops when a contact finishes their 14-day follow-up period with no signs and symptoms. or when a contact is confirmed COVID-19 positive and is isolated and moved to a case list, okay? Or the last two scenarios could be where we have errors in classification in the first place. So subsequent investigation leads to the person being reclassified as a non-contact. In that case, that contact will stop quarantine or monitoring and will be discharged. Another situation is when the subsequent investigation leads to the linked case, that is the index case, being reclassified as a non-case. So in this case, we thought that the index case was a confirmed case, but it's actually not a confirmed case. So in this case, we will have to stop contact tracing. The other scenario, which is not listed here, and we will not want it to happen, is that during the monitoring period, for one reason or the other, the contact dies for some other reason. So in this case, contact tracing will also stop. Next slide. So testing of contacts is a key important notion for contact tracing too. Contact tracing should be supplemented by COVID-19 testing, as you would see tomorrow if you attend the webinar. The contact tracing SOP recommends testing all high-risk exposures contacts, contact persons, whether symptomatic or not, as soon as possible after identified to allow for further contact tracing and case isolation. Or testing could also be done to allow low-risk exposure contacts in settings with which transmission is likely and or the population is vulnerable to severe COVID-19. Also, you can test when contacts become symptomatic. So some of these situations when you do testing will be explained more by Dr. Velomena. Testing of contacts can be done via a mobile service or at their closest screening clinic. I'm sure you must know more than me where you can do testing for contacts in Fiji. So testing recommendation changes when moving from containment to mitigation phases of the outbreak. So these recommendations that we've shared is really for containment, yeah, and not mitigation. Next slide. So what are the data collection tools? There are three main tools for contact tracing. If I can say importantly, there are two main tools. The two main tools for contact tracing are the case listing form and the contact monitoring form. However, we've included a case report form as one of the tools for contact tracing because it's usually important to have this tool to report cases or contacts that show signs and symptoms. So with the first tool, the case report form is to collect personal and clinical, including travel exposure and details of the case. It is usually filled in by a healthcare worker, maybe a medical doctor, or the contact tracing team can happen in a situation. The next tool is the case listing form. And this tool is to list and register contacts as we've seen. Maybe it could be a casual contact, maybe it could be a secondary contact, or it could be a primary contact. And it's usually done by the contact tracing team. The contact monitoring form is the other tool which is used by the contact tracer himself or herself. And it is used for follow-up and to identify or to monitor the health status of the contact. And it is usually used by the contact tracing team. Next slide. So the COVID-19 case report form, actually it is actually a form that you have to fill in when you think someone is suspected of COVID-19 or somebody is probable of COVID-19. So it is usually filled for suspect cases or even probable cases, and should always be filled when an initial diagnosis and testing for SARS-CoV-2 infection is needed for a patient or person. So you must fill this report form. Information is collected by a trained interviewer, and we collect information regarding the identification of the case, the presenting symptoms and signs, the risk factors for exposure, like the travel history. Maybe you have a person in the Eastern Division that traveled to the Central Division. That's a risk factor for exposure. The comorbidities and laboratory information. So all of these, and also the vaccination status, all of these are captured in this form when we want to do an initial testing of a case. Next slide. After you have filled the case report form, you have to also fill in a contact listing form. And this contains information of the confirmed case and also information, preliminary information about the contact. So you would see we have so many variables there. I just want you to note that we have information for the case, the index case, and also information for the contact. So this is where you would list all your contacts and you fill in all the variables that are here. Some important variables that I must highlight is the last contact with the case. That is the date of last contact. We cannot do contact tracing without a date of last contact. So we must identify the date of last contact for each contact. And also, two important variables are the address, the address of the contact, and also the phone number. This is quite important because we can have, during monitoring, contacts that might be lost to follow up. It's true, we've told them to quarantine, but sometimes when we come to supervise and to monitor, the contact is not there. So we would have to locate the contact using maybe the address and also the phone number. And of course, we have to categorize our contact, whether it is a close or partial contact. Next slide. Once this case listing form has been filled, for each contact that we've identified, we have to create individual contact monitoring forms. So let's say in the previous slide, we listed 10 contacts, then we have to have 10 contact monitoring forms. And each contact tracer should have maybe an allocated number of contacts that he or she can follow. So the contact monitoring form is the ultimate tool for the contact tracer. It is designed to monitor the health status of the contact, and generally it should have three types of information. Information about the index case, the case that contaminated the contact, or that the case that was that the contact was exposed to, and also a section for information about the contact, as well as a follow-up section about the signs and symptoms of the contact. So here we can see that we have information about the contact, the age, the name, the ethnicity, the address, and the phone number. Then we have information about signs and symptoms that will be monitored, not only for 13 days, but for 14 days from the last date of contact. Next slide. So just to propose with you the workforce for contact tracing. Generally, we have two groups of human resource for contact tracing. I will start at the very bottom, which is actually one of the most important, are the contact tracers themselves. That's the volunteers in the community. Their role is to monitor contacts, and they should collect daily information regarding the health status of the contact. And they should report to their supervisor in case the contact becomes unwell. And they should also listen to the worries of the contact and share information with their supervisor. It's not just collecting information about the health status. You have to sometimes listen to the contact to know what is wrong or what is not right. So you have to build a good rapport with your contact so that the contact can confide and share information with you. And you should inform the supervisor of contacts that are not compliant to follow up. Contact tracing must not be forced. We need to sensitize contacts to accept quarantine and to accept follow-up. And the contact tracer should support in finding contact lost to follow up in the community. Now, the other roles, the contact tracing supervisor is really like a more experienced contact tracer. And it could be any member of the contact tracing team, like let's say a surveillance officer or members of the rapid response team. So they take part normally first in investigating. Sometimes they can also take part in investigating about the case to identify contacts. And they can also provide initial information. They provide initial information to the contact regarding the tenor of contact, of quarantine and contact tracing. They also plan and organize testing of contacts, and they inform and work with the local health authority to isolate contacts that become symptomatic. They also ensure that contacts have minimal access to essential services during quarantine, such as water and food. And they support the contact tracer in sensitizing contacts that are not compliant, and also ensure that all tracing materials are available. Let's say all the tools that we listed before. And they also ensure that contacts are discharged appropriately. The contact identification is usually now more experienced, if I can say, team who get towards more the side of the health sector. So these last two roles that I shared is usually based community-based roles. But these other areas could also be people of the healthcare workforce, and could be the sort or other clinicians willing to support identification. So what are the proposed tasks for identification? The contact tracing, contact identification and listing team should ensure that contacts, each confirmed or probable case has been investigated, and that interviews every confirmed case to understand the exposure and to map the path of the case during the infectious period, and fills out a contact line list with the details of each contact to include their names and phone numbers, and of course, later share with the contact tracing supervisor. I think generally this is all that I have. Next slide, I'm not sure. Okay, over to you, Julia, thank you.
Thank you, Dr. Elias. So that was a really quick rundown of contact tracing principles. So we hope that you have a better understanding of the basics of contact tracing, the definitions of cases and contacts, the process of contact tracing, and the tools that you'll need to use in the field, and also the roles and responsibilities within the contact tracing team. So we have a couple of resources and guidances, and I'm sure that these slides will be shared at a later date as well. But at the moment, I would like to pass over to Dr. Philo, who would be able to provide some insights into your experience in contact tracing. So thank you very much.
Thank you. Good evening, everybody. Okay, where to begin? All right. So with contact tracing, the screening clinics and the mobile clinics and the mobile screening team is very different. And how you approach your contact tracing in that regard will also be different. I have more experience towards mobile screening teams. We came into EOC or SOT when during the DAV, when the DAV cohort became primary contacts to the index case. So in that regard, one thing that I must encourage and ask everybody is to understand what you are doing in terms of contact tracing. So you must ask the right questions, and from your index case to your primary contact. From the DAV cohort, what I have learned is that when you have your primary contact, everybody else within that household becomes a secondary contact. We do not swab secondary contacts, but we swab our primary contact. And you must allow or must take time to explain to the person that you are swabbing, what does it mean to be swabbed? Because swabbing as a swabber, it's a great responsibility for you to be swabbing someone. And as the person who is being swabbed, they need to understand that once you swab them, they must keep still. So they must be at home. And everybody else who's their secondary contact that they live with must also be at home. So that's something that you need to reiterate and to explain to the families. COVID has gone to a point from our Fijian perspective as breaking cultures, because when you go into a home, they are they ask you to come in. I'd urge you to stay out. Before you go out into the field, understand where you are going, the terrains that you are going into. So go prepared. take your raincoats, take your umbrellas, take your boots, take warm clothing, because you don't know what you'll be up against. Take torches, because some of the contact tracing teams go up right up until the middle of the night to the following morning. Know where you are going. So asking where they live, their residential address, contacting them via telephone is very important. So then you can then stratify and figure out which areas you need to target. So what we've done in SORT is that whenever we give out lists for swabbing teams to go and swab, we have divided them into areas. So for SUVA, it would be Newtown, Khalsa. So areas that are in one particular place, one team will handle that area. So you'll have, so that way you are making it much more simpler for you and your team to be able to target that particular places that you're going to. Contact tracing, at the end of it all, you must be able to give your result to the people that you have swabbed. I know that there's a push more towards the positive results, but remember that your negative result is just as important, because negative result means that there's a sigh of relief psychologically from the person that you have swabbed, as well as the secondary contacts that are there. So day 4 swab, your day 8 swab, and your day 12 swabs. Once you need to be able, again, information is very important. Having rapport with the people that you are swabbing, their families. We've gone to homes where they literally want to chase us out because it's like 2 o'clock in the morning and you are here. Why are you here now? You know, so you have to just explain to them, sorry, there's a lot of things that we had to do. There's a lot of other people that we had to swab, and then be very understanding towards that. So go in, be happy, you know, enjoy what you are doing, but always remember that the main goal is to swab them and give them the result. That's how I see it. So a negative result is important, and a positive result is also just as important. For our positive cases, reassurance is one thing that you have to give them. And again, we've seen it in the media on signs and symptoms. And those are some things that you always have to re-engage and constantly remind the patients that you see, remind the families that you see, that these are the things that you will go through, the phases that you go through from day 1 to day 7, day 7 to day 14. We've had cases at this point in time who have gone through day 14 already and are positive, have been positive, but still have the disease. So and that's where I think if you have seen the letters that we have, the day 14 from the moment that you are positive, 14 days from now, but it is, what shall I say, it is not an ideal kind of thing where it's a one case fits all. So you need to be able to follow up your positive cases. Some of them still remain symptomatic. I've had 3 or 4 cases, it's been day 28, and they're still sick. And so we have teams that go and see them every 3 days to see their progress. Containment phases and your mitigation phases. In terms of your containment phases and your mitigation phases, they're very different. For us, when we were in the containment phase, it's your index case that's positive. Your primary contacts, you screen or you swab all your primary contacts from day 1, day 4, day 8, and day 12. In the mitigation phase, when you have your index case, your primary contact, you can swab, but at this point in time, it's symptomatic swabbing only that we are doing. But even then, the mitigation phase has also changed as well. So for SUVA, for us, for the CWM staff, only the positive cases we are following up. So SORT CWM has now piggybacked with 165. And so we are also taking on the public and also seeing them. And so the positive cases we are following up, and their primary cases or their families, we are closely monitoring. So the ones that are symptomatic, then we will go and swab. If they don't, then we will do their exit swab of day 12 exit swab because they are primary contacts. And then, yeah, so that's what my experience in the field. You will come across areas that are hard to reach. You'll be braving storms, rain. You'll be chased by dogs. Yeah, so yeah, I mean, going out to the communities is a challenge. but have a good team, have that team spirit, and yeah, keep smiling. And just ensure that you allow the people that you are swabbing and their families to understand why you are swabbing and what is the goal and what is the outcome of that. Yes, that's all from me this side. Thank you.
Thank you so much for sharing your experiences, Dr. Philo. And yeah, I know it can be really tough out there, but it's just so important. Contact tracing is the backbone of, the response. So all of this work is so appreciated. And in saying that, I guess I'll pass back to Dr. Alapati now. Thank you.
Guys, thank you for the presentation this evening. Yes, so like Dr. Philo has mentioned, like everybody has said before, this is a very important part of our public health response to try and identify our cases of COVID. I know that from the mitigation phase that we're in at the moment, even though we're not testing, in a few weeks' time, we'll move back to doing the mass testing again once our case numbers have started to drop, and it's very likely that you guys will be going full speed ahead in the West right now with your contact tracing. So yeah, the information shared today, absolutely important. Thank you again to the speakers. Once again, ladies and gentlemen, thank you for your time. It's now 7 o'clock. This is when we bring this webinar to an end. Remember again that tomorrow we have Dr. Alicia, who's coming on to talk to us about the rapid testing, the RDTs that's now being used in a few places. And it's going to be interesting to see how we can disseminate this information a little bit more. But once again, thank you very much. Stay safe until we meet again. Have an awesome evening.
Thank you.